You talked about something in our last segment, polyps and colon cancer screening. Now, I turned 50 last year. I just turned 51.
They got you.
And they got me because I did a FIT test, fecal
histochemical test. Yeah.
Yeah. Say that again for me.
Fecal immunohistochemical test.
That's right. I'd forgotten what it stood for. FIT, if you're nasty. I did that. I pooed in a jar that you put over the toilet, and it was really a lot of fun.
Hat.
It was, yes. I like jar because it made me feel like a child playing with my own poop. So you crap in this thing. You this incredibly complicated
and this was the specimen that this was
the actual specimen. Yeah, it's for people who are just listening on the podcast. Vinay just handled my feces.
There's a poop emoji.
A poop emoji. A physical poop emoji. Yeah. You poo in this thing, and then there's this complex box that you have to fold exactly right, or
like origami.
Like origami, or the mail carrier will have poo on them because it will leak.
I see. Errant feces.
Yes, errant. So you're thinking about a 75-year-old with mild dementia trying to do this, literally do this shit. See, even my dad would say it is shit. Yes, this is shit. And so you do it and you send it off and they run the thing, and mine was negative. But apparently you have to do it every year. And apparently insurance doesn't cover it. So it was $632 for me under my plan at the time.
Interesting.
And so I said, okay, well, you're telling me I can just do one colo once and get it done and get 10 years.
Get a maintenance certification for 10 years. Get your 10-year certificate.
I did it. My ass is clean for 10 years. Yeah. All you have to do is be probed. Now, I wasn't going to do it because I heard Vinay's voice in my head saying, what is the number needed to treat with colo? How many perfs happen because we're giving people lots of sedation? And if you do a biopsy and they're very sedated, you can't tell they're in pain, and you perforate and there's free air and it's a disaster. So I was like, no, I don't really want to do this. But then my wife was like, you know what? I'm going to do it. And I'll do a run for you. She didn't do fit or anything. She's like, I'm just going to do it and be done with it. She wants to do it. Okay, fine. She goes and does it. She comes back. I pick her up from the thing. And she's like, that was the smoothest thing ever. Like, they give you fentanyl and Versed. It's like so great. And I was like, I've never had fentanyl and Versed. I'm like, sign me up. So now I'm like, well, the way they do it here, I was like, all right, I might as well just get it done. Now, talk me through this, man. What am I doing?
Wow.
I'm doing what the guidelines say, and I'm late, actually.
I guess one question is, did you get FIT or did you get Cologuard? Did you get like fecal DNA testing?
Oh, great. Or
did you actually get immunohistochemical testing?
Great question. I think I may have gotten Cologuard, but I'll have to look.
I see. Because Cologuard is the more expensive one, and that's why insurance usually covers every 3 years.
That's probably what I did. And I should know better, but honestly, I just thought it was so hilarious, and I forgot about it entirely.
There's a few tests, but I think that
Cologuard is probably what I did.
Maybe, which is probably why they don't want to pay for it twice. Okay, so I don't know. What do you want to know about colon cancer screening? I guess I'd say
help me. Okay, I'm 51. Like, should I just go and get a colo? What's the deal with?
Well, one is you should know that the American Cancer Society has moved the recommendation down to 45.
That's right.
Which is a recommendation they pulled directly from their ass. Because actually there is no randomized data from 45 to 50. It's only 50 and above. Okay, so just briefly, I'll give you the brief summary of the data.
Yes.
Okay, so we now have randomized control trial data for screening average risk individuals who are asymptomatic for colorectal cancer for several modalities. One, colonoscopy, one randomized trial called Nordic. Flexible sigmoidoscopy, several randomized control trials of FlexSig, which is like half of a colonoscopy. You look at the left side. You can often use enema to prep rather than drink the whole bucket of Go Lightly and shit yourself the night before.
The prep is brutal.
The prep is brutal. Yeah. That's a great Lewis Black comedy special, which is he's like, colonoscopy, that's a breeze. It's the night before.
It's the night before. Yeah, exactly. Yeah.
So we have many randomized trials for FlexSig. We have randomized control trials for FOBT, which is fecal occult blood test, the older one. And then from FOBT, what we learned about that, we've leveraged that to fecal immunohistochemical testing, and then to things like fecal DNA testing like Cologuard. And then there's a new recent New England Journal paper on this as well. And finally, we have blood-based cancer screening, two different blood-based screening tests. One that's been approved and looking at methylated markers on DNA for a colon cancer screening test. And finally, you have CT colonography. Okay, CT colonography, no randomized control trial data. The blood-based cancer screening tests, no randomized control trial data looking at like death from colorectal cancer. And really, in my opinion, very poor sensitivity for like early disease and like not a good idea to do. I'm surprised
the blood test.
The blood test, yeah. I'm surprised it wasn't even approved. Okay, of all these things, the one with the strongest evidence, like if you pool all the randomized studies, there's a clear reduction in death from colon cancer, and there's a reduction in death for any reason. So like the strongest is for FlexSig.
SIG, yeah.
FlexSig, which is why most of Europe does FlexSig. Easier prep, it's cheaper, less risk of perf, it's quicker. That has the strongest data. FOBT lowers the risk of colorectal cancer death, but in pooled analysis, it never improved all-cause mortality. There's no proof that translates to that. The Nordic study is so far has found more colorectal cancer by getting the screening than not getting the screening. It's not yet found a reduction in colorectal cancer death that's significant. There's some people who say that's because not everyone who assigned to colonoscopy got the colonoscopy. That's true. Only about 60% of people in the high country got the colonoscopy. So
it's an intention to treat type of deal.
Yeah, intention to treat. But the counter argument is, so if you look at a per protocol analysis, people who did it versus people who didn't do it, it looks favorable, but that's not the right way to do it. You got to look at something called instrumental variables, and it's still negative by that metric. Okay, that's a long story. Okay, now here's what the takeaway points. What I would say is, I think of all the cancer screening tests, mammography, PSA, lung cancer screening, colonoscopy, this is the one that I have the least problem with, okay? Because I think colonoscopy is both a screening test to look for colorectal cancer, but it's also a preventative test to clip a polyp before it becomes cancer.
Right.
FlexSig, I think, has the strongest data. And if the United States were a sensible nation that was practicing evidence-based, high-quality care, which we're not, but if we were, we would be recommending FlexSig for everyone until colonoscopy proves it's better than FlexSig, which it has not done. But because we don't do that, because at the end of a sigmoid, there's only a $400 bill, but at the end of a colon, there's a $2,000 bill. We do colonoscopies. But I think a colonoscopy is at least a FlexSig, probably. So it's probably going to have that same benefit. Nordic will probably have that benefit with time. If I was like in charge of all policy, I wouldn't prioritize that. But if somebody gets that done, I think that's reasonable. FIT done yearly, I think is probably reasonable.
I think at Kaiser, they do offer that.
They do offer that, yeah. I think the evidence is weaker for FIT than it is for FlexSig, certainly. They don't have all-cause mortality benefit. They don't have direct randomized data. They're extrapolating from FOBT.
And if it's positive, you still have to go get a colo.
Yeah.
Yeah.
Now, all this said, I think there's something that I hear John Mandrola in my ear, and this is what he would say. He'd say that, we spend all this time focusing on one type of death, colorectal cancer death. But in many of these studies, it's something on the order of like, 40 people die of colorectal cancer, but